are younger. It doesn't necessarily have to be, but typically they are younger in age. Maybe a child, maybe a teenager, but very often early. And then type 2 diabetes is the one we think of people that get older, have bad health, have diabetes in their family, non-healthy diet, maybe overweight, and that's the type that older people typically tend to develop. We're also going to talk about cardiovascular disease, patients who get pregnant who already have heart disease, respiratory disorders like asthma, skin disorders, autoimmune disorders like lupus and Crohn's disease and things like that. We'll talk a little bit about substance abuse, which we've touched on already. And then we're going to talk about HIV in a little more detail and how that affects a woman during pregnancy. Okay, so diabetes. This is a disease that really wreaks havoc on people, and pregnancy is no exception to that. We can still have poor outcomes. Some of you guys have already talked about being over in clinical and being over in NICU and seeing this great big fat baby over there, and it was there in NICU because mom had diabetes. So diabetes is something we really have to spend a lot of time working on to make sure we get good outcomes for mom and baby. So diabetes in and of itself, what does it mean to have diabetes? It means it's a disease process that is characterized by hyperglycemia. So what's hyperglycemia? Too much sugar in the blood. Hyperglycemia, too much sugar in the blood. So when you eat something sweet, that sugar starts being released. Once it passes into your stomach and it starts being released into your bloodstream, and then your bloodstream has to get that sugar out of the blood into the cells where it's needed to function, right? For you to function. So how does your glucose get out of your bloodstream? What drives it out of the blood? How does your sugar leave the blood? What is secreted that would cause that to happen? Insulin is secreted by what? What organ? The pancreas, yes. So the pancreas secretes insulin. Insulin drives the sugar out of the blood, out to the cells where it can be used. So diabetes can be caused by one of two things. Either impaired insulin secretion, meaning you don't have enough insulin, your beta cells in the pancreas aren't working. That's one reason. Or number two, inadequate insulin action in the target tissues. So of those two things, which one of those is type 1? Is it impaired insulin secretion or is it inadequate insulin action? Impaired secretion, your beta cells aren't working when you have type 1 diabetes. You have no exogenous insulin or endogenous insulin. You need exogenous. You have no endogenous insulin. Inadequate insulin action in the target tissues, that's type 2. In that case, you've got beta cells that are working, but the insulin action is not working quite right. Okay, so there are overall, all encompassing, 4 types of diabetes. Type 1, which means you have no endogenous insulin, your beta cells aren't working. And what do you all think causes type 1 diabetes? Anybody know? What's the cause of type 1 diabetes? We believe that there's an autoimmune component to it. We believe that some people get a viral syndrome. Like kids will have a viral syndrome, and after that, it triggers something to begin in the body, and that is autoimmune related. This is an example of an autoimmune disorder coming from a virus. It's not diabetes, but for example, my niece, when she was about 6 years old, had a really bad respiratory virus, and 2 months later, her platelet count was like 10,000, because she had ITP, idiopathic thrombocytopenia. And it came from a viral syndrome that wreaked havoc on her hematologic system, and she ended up with ITP. Now, we've seen the same thing happen with a lot of kids, but it didn't affect their platelet count. It can affect their blood sugar. So you can have a viral syndrome as a child, and 3 months later, your child's not feeling well, just can't seem to get to the bottom of it, take them to the ER, their blood sugar 700. That's usually how they diagnose type 1 diabetes. That's usually what happens. Kid or a teenager just not doing well, they're just drinking all the time, and they want to sleep all the time, they just don't feel right, can't, break them out of that funk, and they go to the ER, and their blood sugar is 500, 600, 700, 900, something like that. So that's type 1. Once that's diagnosed, that patient has no insulin, they will not have insulin the rest of their life, or at least not enough to function, and so they're going to need insulin for life. This is probably the worst kind of diabetes to have because it usually starts when you're young and it's going to last your whole life, and you're going to have some long-term repercussions from type 1. So what we've got to think about is what impact is a type 1 diabetic who gets pregnant, what impact is that going to have on her? It's going to have a significant impact. Now, type 2, remember, is the type we think about of our older person who's 60 and who's overweight and maybe who smoked and has had diabetes for 20 years and they lose their toe and then they lose their foot and they eat they eat everything in sight. They don't stay on their diet. Type 2 is genetic, has a genetic component. Type 2 is related to your diet and your, if you're obese. So that's what we think about a type 2. So do you think there's a lot of type 2 pregnant women out there? Not really, because most pregnant women are in their 20s, maybe their 30s. If they do have type 2 diabetes, it hasn't had time to get really bad yet. The only exception would be somebody who's really, really obese. Let's say we have a 39-year-old patient who weighs 350 pounds, has type 2 diabetes. That might be a case where it would be a problem. But for the most part, we don't see a lot of type 2s who are pregnant women. They're just not old enough to be that sick with it yet. They're young. Type 3 is other specific types caused by infection or drug-induced. So let's say you have a terrible infection and it affects your pancreas, or you do something, you have pancreatic cancer, or you have something drug-induced that destroys your pancreas. That's type 3. So anything that would destroy your pancreas was not type 3. It's number 3. It's just the other. It all falls into that other category. And then number 4 is gestational. So gestational diabetes is any degree of glucose intolerance with recognition or onset during pregnancy. So any time the patient has blood sugar issues that start during pregnancy, that's called gestational diabetes. It only starts during pregnancy. It only happens during pregnancy. There are a whole bunch of different kinds, A, B, C, R, T, all kinds of different. There's a chart on page 245. It's called White's Table of Diabetes Pregnancy Classifications. I'm only going to ask you to know 2. There's a whole bunch of them, but you only need to know 2. Type A, gestational diabetes is diet control. That means we discover the patient's diabetes during pregnancy. It's gestational, meaning it didn't start till she became pregnant. And we put her on a diet, and we're able to control her blood sugar easily with diet. 75% of the time when you have gestational diabetes, this is the kind that you'll see. They get diabetes during pregnancy, we put them on a diet, they follow it, they do well. That's type A. Type A2. Type A2, on the other hand, requires medication for control. So, again, the patient has diabetes, we diagnose it during pregnancy, we try diet, doesn't work, try medication, that works. Type A2 requires medication for control. Medication is going to be either regular insulin or an oral agent. We don't typically use any long-acting insulin for our gestational diabetes. Diabetics, we try like metformin or glyburide first, and then if that doesn't work, then we'll try regular insulin. Type A through C are associated with positive pregnancy outcomes, as long as we keep the patient's blood sugar close to normal. Types D through T, poor pregnancy outcomes. And again, you can look at the table to see all the different kinds. Like, for example, R stands for retinopathy, which means it's so bad they've got retinopathy in their eyes. But A and A2 are all you are required to know for testing purposes. Okay, this slide, take your textbook, it's very important. What this slide represents is what are the insulin needs of a pregnant woman and how does it change during the pregnancy. So insulin needs basically mean what's your blood sugar running, but your insulin has to, what does your insulin have to do to control it? So if we look at pre-pregnancy right here, and then we get the first trimester, and right before the first trimester up to about 13 weeks, it actually drops. Insulin needs drop. What do you think is responsible for that? Why would your insulin needs drop in early pregnancy? I mean, when I say early, it's probably more along the lines of 8 to 10 to 12 weeks.
Would that be the need of the baby?
Well, your insulin needs are lower. You're needing less insulin, so your blood sugars are running lower. So why would they be running lower? What's going on in your body when you're at that point?
Morning sickness?
You're sick.
Oh,
You're
yeah.
sick. You're not you're not eating. If you're not taking anything in, you don't need a whole lot of insulin, right? Most patients are sick. They don't eat as much in early pregnancy. They don't feel well. Certain things smell bad. So they have decreased insulin needs because they have decreased decreased food intake. Does that make sense? Okay. So their insulin needs go down till about right after the beginning of the second trimester. And you see they're very steady until about 20 weeks. What happens at 20 weeks? It takes a steep, sharp increase, right? And that increase goes all the way to 40 weeks to term. So this really represents the baby's growth. As the baby grows, the insulin needs grow, right? So the pregnancy's progressing, the baby's getting bigger, more placental tissue, more amniotic fluid. So everything about the pregnancy is requiring more insulin of the patient. More metabolism's going on. So her blood sugars must be higher because she's requiring more insulin. At birth, at 40 weeks, which represents birth in this picture, what happens at birth? It does a sudden and nose down, right? So as soon as the baby's born, it literally goes down almost back to where it was at its lowest point, all the way down below what it was at 13 weeks. And then, depending on whether you breast or bottle feed, you can see it may be a little bit different. But it drops dramatically at birth. So, looking at that chart, what parts of pregnancy are going to be hardest to manage for the nurse for a patient who's diabetic? Weeks what to what? Her insulin needs are going up in weeks 20 to 40, right? So our problems are going to occur for weeks 20 to 40 because your insulin needs are going up. You're needing more and more insulin. So if you're a type 1 diabetic who doesn't have any insulin, and you've been stable on your dose of insulin for years, you've got your NPH dose, you've got your, a lot of those long-term diabetics who've been diabetics for years, they know their insulin inside and out. They know their diabetes better than most doctors. They know their own body. But now pregnancy comes along, everything changes. So their insulin needs, what did manage their diabetes, clearly now will not, as that goes up and up and up. So we're going to have to constantly change. Can you see how we would have to, somebody who's on insulin every day, we have to constantly change their dose almost daily, if not weekly. Maybe weekly, but maybe even daily or every other day. It's going to change significantly. So I want to make sure that you understand what the needs are as the patient progresses through pregnancy. So this is just a normal person. So if you add diabetes into that's pre-existing or gestational, it's really, if they don't have that insulin because they have diabetes, then we're going to be in trouble. They're going to have some significant hyperglycemia. So this line represents insulin needs. So that means the blood sugar must be going up. If we need more insulin, then it must be because the blood sugar is going up, right? Everybody following me? Okay, good. Okay, so now we're going to split out and talk a little bit about each type of diabetes. Let's start with type 1. If you have type 1, remember that's the person who's a child or a teenager who gets diagnosed with diabetes because the example I gave you a minute ago, they're sick, they go to the hospital, their blood sugar's 900, 800, whatever. They get them under control, they get on a regimen, they see an endocrinologist, everything's working, going well, they've got 2 or 3 doses of insulin a day, they're in control, maybe they have an insulin pump even, things are going well, what happens? They get pregnant. And so for that person, there's some things that we have to look at really carefully and closely for our type 1 diabetics. Number 1 is preconception counseling. Type 1 diabetics, we do not want them to get pregnant if their blood sugar is not in control. It's extremely important that they don't get pregnant until they get their blood sugar under control. Let's say you have a 20-year-old that's diagnosed with type 1 diabetes. They would be counseling her, do not get pregnant while your blood sugar is 800. Do not. You've got to wait until your blood sugar is under control, until we get you managed. Because what happens is, one of the biggest causes of fetal anomalies of all is a patient with hyperglycemia at conception. If you have hyperglycemia at conception, you are at significant risks for cardiac, skeletal, and CNS system anomalies. Very, very high risk. So achieving glycemic control. Achieving glycemic control, what does that mean? In simple terms, layman terms, what does that mean? Achieving glycemic control means what?
Having it within normal.
Having your blood sugar within normal range, having it in control, not wide variations throughout the day. It's stable, it's staying in control for the most part. So that's critically important at conception that your blood sugar be under control.
What are the people?
They're all on the other slides, but it is cardiac, CNS, and musculoskeletal, I believe. But I think it's also on the next slide. Maternal risks and complications for pre-gestational diabetes, of course, is either type 1 or type 2. But type 1 is what we're talking about right now. A lot of our diabetics who have type 1 have episodes of DKA. You all know what DKA is, right? Diabetic ketoacidosis. Have you all done acid-base balance yet or no? Not this semester. Not this semester. Okay. So you will be talking about DKA when you do acid-base balance. And you will be discussing DKA because that's one of the main causes of metabolic acidosis. A lot of type 1 diabetics have incidences of DKA. If you are pregnant and you have type 1 diabetes, you will get DKA at a lower blood sugar level than you would pre-pregnancy. So if your body tends to throw you into DKA at a blood sugar level of 750, when you're pregnant, it might be 450 or 550. But incidences of DKA will be more frequent and more severe than when you were not pregnant. Hypoglycemia. A lot of diabetics, also, you probably all know somebody who had diabetes whose blood sugar would bottom out and they just become almost comatose, and you have to, give them, used to give them juice, now give them milk and crackers. You have to do that to try to get their blood sugar up. So for women who have hypoglycemic episodes outside of pregnancy, it will be more severe during pregnancy. The incidence will happen more frequently. In addition, another complication of type 1 diabetes is polyhydramnios. What is polyhydramnios? Anybody know what that is? Polyhydramnios is too much amniotic fluid. So if we have too much amniotic fluid, let's think about what that would cause in the body. We're going to come revisit this again. So you have too much fluid in the uterus, more than you should have. You don't need to know the number, but it's usually greater than 20 or 25 centimeters. That is not important for you to know. You just need to know that polyhydramnios means too much amniotic fluid, and diabetes can cause it. So what do you think happens to a pregnancy when you have too much amniotic fluid? What are the dangers of that, what do you think? Too much fluid inside the uterus. What's that going to cause? What are we going to worry about? What? Well, it's not so much organ, it's something that's going to affect the pregnancy. What'd you say? Well, possibly a cord, if there's a lot of fluid, your cord may float around a little bit. But think about what you're doing. You're putting lots of extra fluid in there. So it's going to make your uterus do what? Stretch, 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 right? So what do you think would happen if we think of your uterus like a balloon? We stretch it, stretch it, stretch it, stretch it. We stretch it out enough, what's going to happen to it? Rupture. Any organ that becomes overdistended to the point where it's past full, we risk rupturing. You'll hear about uterine rupture later, that'll kill a patient like that. If uterine rupture, you're not in the hospital, you're gone. Because you bleed to death. So stretching that uterus out, stretch, 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 it only goes so far. In addition to that, one of the things that tells the body when to go into labor is when is the uterus full. When your uterus becomes as full and distended as your body thinks it should get, you go into labor. So if it's not baby that's stretching it out, but if it's fluid, then what might that cause? What kind of labor? Preterm labor, exactly. So the more common thing we would say would be preterm labor. That'd be the most common thing. Uterine rupture would be the extreme, and we certainly wouldn't want that to happen. But preterm labor would be the most common thing. Too much amniotic fluid is going to tell the body, oh, it's full. Just like if you have twins or triplets or quads, that's why you go into labor early. When your body senses that the uterus is full to its maximum capability, the body tends to go into labor. So you're going to trick your body into thinking you're in your full term, and you're going to go into labor. Okay. Another risk of pre-gestational diabetes or type 1 diabetes is sudden stillbirth, IUFD, intrauterine fetal death. Often it's usually if we look, it's going to be attributed to acidosis, to metabolic acidosis from DKA. 2 to 5% of all intrauterine fetal deaths are caused by complications of diabetes, usually again DKA. So, congenital anomalies, like I mentioned a few minutes ago, there are, a lot of congenital anomalies will end up causing a miscarriage. So, a lot of times patients who have miscarriages not realizing that there was something wrong with their baby, and that was the way that nature takes care of some pregnancies if it's a severe anomaly. So up to 50% of perinatal loss in pregnancy we can attribute to type 1 diabetes, believe it or not. That's a lot. And what happens is we have hyperglycemia during the first trimester. So our patient blood sugar is not under control, right? So we see central nervous system, cardiac defects, and skeletal defects. We can also see birth injuries caused by fetal macrosomia. Anybody know what fetal macrosomia is? Big baby, above 4,000 grams. 4,000 grams is about 8 pounds, 14 ounces approximately. And it's usually the result of what we call shoulder dystocia, or the shoulder gets stuck, so we'll talk about that in just a minute. Brachial plexus palsy, this is the brachial plexus nerve. If the head gets stuck and we stretch the neck out and we stretch that nerve out, you can have palsy from that. Facial palsy, clavicle fracture of the baby, and of course hypoxia to the baby. So, if we have a baby that's very big, now think about it. When you have a pregnant woman and she's taking in a steady supply of sugar and her blood sugar is staying elevated because she's not under control, that's going to affect the baby's glucose levels, right? So think about your baby getting a big, steady supply of sugar. You have a very happy baby. They're kicked back in the uterus and bring on the sugar, and they're happy as clams. But they grow and they become very big. So a lot of times you'll see these babies be 9 pounds, 10 pounds, 11 pounds, if the mom's not under control. So an 11-pound baby is completely, totally happy before birth. But then it's time for birth. First of all, how do you get an 11-pound baby out? There are very few women who can deliver an 11-pound baby or even a 10-pound baby. So we worry about getting them out. They're not fitting. So they're increased risk for C-section, or sometimes they get the head out and then the shoulders won't come out, which is called a shoulder dystocia, which we'll talk about when we talk about birth complications. The shoulder dystocias can lead to hypoxia, clavicle fracture, humerus fractures, all kinds of things, all kinds of bad things. And then what happens after that, and this is important, we'll talk about this again and again. So let's say we finally get the baby out, whether it's by C-section or vaginal delivery, we get the baby out. And they've been used to a steady supply of sugar for months. They're kicked back, like I said, happy as clams, sugar, bring on the sugar. Sugar, sugar, I'm so happy. We cut the cord. What happens to the sugar supply? Gone. They have not had to manage their blood sugar in any way, shape, or form because they've been getting a steady supply of it. So what do you think happens to their blood sugar after birth? It tanks. They become very hypoglycemic, sometimes severely after birth. So they've been getting that sugar rush for months. Sugar, sugar, sugar. Cut the cord, the supply is cut off. The happy juice is gone, no more sugar. So their blood sugar drops. Now we have a baby with hypoglycemia, and we've got to deal with that. Okay. So for our patients with type 1 diabetes, what we usually do is we put them, again, they've had something done before pregnancy that they've been doing. And what's hard with these patients is this. They think of themselves as experts for managing their blood sugar, and they are experts. Like I said, they know their own body sometimes better than the doctor. But now they're pregnant. And what we have to convince them of is that just because you know your body when you're pregnant doesn't mean you know it, or when you're not pregnant, doesn't mean you're going to know what to do with yourself when you are pregnant. So it's very hard sometimes to convince them to let us manage them. Because we want to change their glucose levels. We want to change their diet and their insulin based on their glucose levels. And they'll say, oh, no, I know what happens. If you give me that much insulin, I'll bottom out. You can't do that. I've been a diabetic for 10 years. Yada, yada, yada. They've never been pregnant. pregnancy changes everything for these people. So convincing them to do what we want them to do sometimes is very difficult. They can be very non-compliant because they've been experts in their own care for so long. And again, have done a good job, but they've never been pregnant. So we'll put them on a diet, typically 2,200 to 2,400 calorie ADA. So that means essentially we're talking about a 2,000 calorie diet for them. And remember, you got the 400 extra for baby. Insulin therapy, if needed, if they were on insulin before, they're going to be on insulin now, and we may adjust the doses. We will monitor their glucose levels as frequently as 4 to 6 times a day. It's going to be crucial, especially early on, to monitor their glucose levels. We'll come back to what we want to see a little later. Once they get into the 3rd trimester, we've got to start watching our baby. Remember I talked about fetal loss, intrauterine fetal death. We don't want that to happen. So during the 3rd trimester, we will do tests that you haven't learned about yet, called non-stress tests, biophysical profile, Doppler flow. Those are tests that we do for fetal well-being. You'll learn about those here in just a few days. But they're fetal well-being tests during the 3rd trimester. Assess for polyhydramnios, and we just talked about that. Remember, that's a risk factor for pregnancy, too much amniotic fluid for pregnancy with diabetes. So we look for, how do you think we diagnose polyhydramnios? How can we find that?
Ultrasound.
Ultrasound. Yeah, we look at an ultrasound. And I will tell you, a lot of times you can predict it by looking at someone's belly. If you kind of press it, it just kind of bounces like a balloon full of water. Very often you'll find polyhydramnios when you do an ultrasound. Determine birth date and mode of birth. Why is that significant? Well, because if their baby already weighs 10.5 pounds, we probably don't want to let them go to 41 or 42 weeks. We better get them delivered maybe at 38 weeks. Or this is the, I've preached against induction of labor, but this is a medical problem in which induction of labor is called for. So, yes, if there's a medical problem, it's called for. And in this case, there certainly is. So maybe if they do an estimated weight, and if the baby's estimated weight is 11 pounds, maybe they'll just do a C-section and not even do a trial of labor. That's possible as well. Family planning and contraception postpartum. Again, we do not want a patient to get pregnant if her blood sugar is not under control. We talked about that a few minutes ago. Why? Tell me why. What are we concerned about a patient getting pregnant when her blood sugar is not under control? Well, I just tell you a minute ago. Congenital defects, hyperglycemia at conception, increases the risk of cardiac, skeletal, and central nervous system defects, right? So we want our patient's blood sugar to be under control when they conceive a baby. Okay, so now we're going to switch gears and talk about gestational diabetes. Any questions about our type 1? And I didn't talk much about type 2 because we don't see it often, but we would treat them similar. We're just going to treat them based on their blood sugar. But they have the same risks as type 1, if we even see them. We just don't see them very often. Okay, gestational diabetes means the patient was diagnosed with diabetes after they became pregnant. They're not diabetic. They've never been diabetic, unless they were pregnant or were diabetic with their last pregnancy. But other than pregnancy, they're not diabetes. They're not diabetic. Okay? So, we're going to talk about, maybe we should talk about the screen first and then come back to it. Okay, let's talk about diagnostics, then we'll come back to the slide. So how do we diagnose gestational diabetes? The first time we screen patients is at 16 weeks. So before 16 weeks, we don't even suspect diabetes, gestational diabetes. It takes about 16 weeks of pregnancy so you can get a patient to a point where they would probably be diabetic. And it's really more often found at the 28-week check than it is at the 16-week check anyway. So is our first trimester patient going to have diabetes, gestational diabetes? No. So if somebody who's 6 weeks pregnant has diabetes, what type is it going to be? Type 1 or 2. Mostly it's going to be 1, probably, but it could be type 1 or 2. Type 2, like I said, we don't see a whole lot, but it could be type 1 or 2. So gestational diabetes is not going to occur until midway through the 2nd trimester. So we'll do a fasting blood sugar and 2-hour post-glucola at 16 and 28 weeks. Y'all know what the glucola is? The nasty stuff that you have to drink. It's like either Coke or orange pop kind of thing. It's full of sugar. And what we do is we have a patient, we do a fasting, then we have them drink the glucola. 2 hours after the glucola, we do another lab blood sugar. What we want to know is, what did the sugar do? If their fasting was 90, what happens after they drank all that glucola? It's going to go up, but eventually it'll come back down. But how high does it go up? How long does it take to go up? So the fasting should be below 95. That's what we're looking for there. Your fasting should be below 95. The 2-hour post-glucola should be below 140. If it's above 140, we can do one of two things. Some doctors will do a 3-hour glucose tolerance test. Some doctors will just diagnose. Do you all know what a glucose tolerance test is? A glucose tolerance test is done to really it's the gold standard for diagnosing diabetes in any person. What we do is we do a fasting. Then again, we give the patient the glucola, the drink, and then we take their blood sugar. In this case, with a glucose tolerance test, 1 hour past glucola, 2 hours past glucola, 3 hours past glucola. You can even do a 5-hour post glucola. Do it at 3 and at 4 and then at 5 hours even. So the doctor can say, I want a 3-hour glucose tolerance test, I want a 5-hour glucose tolerance test, whatever they choose. What they want to see is, how high does it go after a sugar intake, and then how long does it take to get back down? Where does it go back down to? That's what they're looking for. So again, in a pregnant woman, if the 2-hour post-glucola is 180, they may just say, okay, you're diabetic. Or they may say, let's do a glucose tolerance test and confirm that. Either one. So your patient, let's say now, is 16 weeks. You had her post-glucola test, and it was 190, and we decide that she's diabetic. So immediately they will start teaching her about doing home glucose checks 3, 4, 6 times a day. We'll begin with diet and see if you want to try the most simple thing first to see if it works. So we're going to put her on a diet first, with her checking her blood sugar, and see if that's effective. If it's not effective, then we'll look at other things. But obviously, you want to start with the most simple thing first. So, what are things that are going to be key for a patient to be successful once we've diagnosed this gestational diabetes? What are things that are key for our success in managing this patient? Keeping her glucose under control, but how do we do that? We have to have somebody who can understand what we're saying, can check their glucose 4 or 6 times a day, is willing to check their glucose 4 or 6 times a day, that they understand how important this diet is, and that they're willing to follow it. So can you see how we're going to get into trouble with compliance here? Some patients just basically ignore you. I mean, I'm not kidding. They say, okay, and they come back for the next appointment, and they haven't done one thing you told them to do. That happens more than you can imagine. And they haven't followed one instruction. They don't, they might have checked their blood sugar once or twice, not even a fasting. And then it's hard to know what to do with them. So compliance is going to be key here for managing these patients. We have a pregnant woman who has diabetes, and now she has to do things she's never done before, and they're not happy. When you tell them, they are not happy. Even if they're good compliant patients, I can tell you, I had 3, myself personally, I had 3 kids, and my oldest one was born when I was older. I was 38 when my oldest one was born. I had never had gestational diabetes ever, but I was 38 by the time I had the third one. So the older you are, the more likely you are to have gestational diabetes. So I had a touch of it. And I can remember when they told me, I was devastated. Because I knew what it meant. I knew that I had to check my blood sugar how many times a day. I knew I would have to stop drinking pop. I knew I'd have to change my diet. I got it.
They're in a coat.
So, even for me, who was a nurse and who understood the ramifications of it and knew how important it was that I followed all those rules and that there were reasons for it, I didn't want to. I didn't want to at all. And, it took me a couple weeks to get myself to do it. And I kept going into denial that, that it was, I thought, maybe it really, can we recheck it? Can we check it again? Maybe it really isn't true. And I'm a nurse who knows OB. So think of a patient who doesn't have any medical background. They don't really understand the significance of it. they don't understand the significance of not following instructions, it can be very difficult. Yes.
I was gonna say, if I can, add to that, there's also the extreme. I had, attentive nursing staff, which I appreciate, but because I was an older patient, they kept telling me I was going to have these problems. And I'm like, I don't know, I'm not. I refuse. And I didn't. I mean, it got so bad to where apparently they didn't realize how old I was because at the time I went to a different place for ultrasound. And a few hours after a glowing ultrasound, I have this panic lady on the phone from the doctor's office saying, "Do you want an amnio?" And I'm like, "Not unless you're telling me the glowing ultrasound I just had 2 hours ago is null and void because I'm older." So it was like that throughout my whole pregnancy. It's crazy.
Well, if you're older too, it precipitates a lot of that to occur, unfortunately. But, you can have all the knowledge in the world, but when you're told that, you have something and you don't want to have it, you go into a state of denial. Denial. So not only is it hard for, somebody knowledgeable, it's even harder for someone that's not knowledgeable. And it can lead to really not being, not being compliant. And I'm sorry, I didn't mean to get distracted. I'm gonna give you a break in just a minute because I just got a message that they're going to try to send my dad back to the hospital today, which we totally did not expect. So, I'm happy, but I'm like, we weren't ready for it.
Yeah.
So go ahead and take a little break. I want to have a break.
She's like, I'm happy, but I'm in West Virginia. Like, she's freaking out. Yeah, I don't blame her. I'd be nervous
I'm
too.
4 hours away. What do you want me to do?
Her sisters are there, aren't they? Didn't she say that her sisters stay?
I don't know.
But still.
Yeah, it just
scared me at first, so I was scared.
It's
not that I didn't like her.
She's bad because
I don't like her. She's fine. Yeah, she is a good
I mean, you
nurse.
just feel like it's trying to tear out of my abdomen. I hate having endometriosis. Cramp, like 6 weeks out of a month. That's how I feel.
Knock on wood. I've never had any of those problems.
Well, I keep debating. Like, my doctor offered to do a hysterectomy, just the uterus, not my ovaries or anything. But with my ovaries, endometriosis can still grow. I mean, I won't have the
So would you get
bleeding.
like cysts on your ovaries?
Well, I guess maybe, but or just the scar can just grow in the abdomen. Still attached to the bowel, still attached to my bladder, still attached to my ovaries. Could attach to everything that's in there, but I just wouldn't have the extreme pain of a period. I don't know. It's like, but then, you have all the other issues of having the surgery, that causing scarring. I don't know. I might do.
I mean, they say hysterectomies are super easy like nowadays compared to what they used to be.
Yeah, because they could just go in there and cut and it just comes out your vagina now. Which that's a plus instead of having to open it up. But, I don't know. I think I might do it because I'm telling you what, this is a bear. And I'm not even on my period. Not yet. I still have like a week.
But you still have treatment and all that, just like
Yeah. I am today. I mean, it's not every day. It's getting worse. I mean, my baby is 7. She just turned 7, and like it's just now getting bad. So I'm fortunate because it was really, really bad before my pregnancies. Like I was passing out the first 3 days of the period. Like I would just pass out. I was pale, anemic, severe around period time. The cramps were so unreal that like I couldn't function. I couldn't go to school.
my periods are like that.
I couldn't function.
Like I get sick, thrown up sick. My face is like as white as that
Yeah.
freaking paper. Like
I
it's
had,
bad for the first like 2 days.
Yeah, I had a laparoscopic done. I had DNC done. I did the birth control. The birth control made it worse, made me sicker. And then he's like, well, the only options are to stop your hormones completely or get pregnant.
No.
So I'm like, yeah,
Is that one of
let's get me
your,
pregnant. Took 6 years.
Yes, babies.
6 years to get me pregnant. Going through all that fertility stuff. It was horrible. Horrible.
I bought some white. I'll just wash my
No,
hands.
no, you want to right out there.
There
I'll
you
buy
go.
it for this.
Just take
I
it.
just like to wear them anyway because
I
the
can't.
buttons
too. Yes.
on your mask and on your ears.
Yeah.
And then you can also hold
Maybe it is, maybe
and
that's
then hold
possible.
on with the mask.
Yeah.
So I like it.
All right, let's not
Plus, it keeps my hair out of my face.
Okay. Fair enough.
I needed to.
What's happening?
I needed to holler at you
Oh, really?
in a little bit. I needed to holler at you in a little bit to ask you about. Carol said that you had paid that man, and you were going to donate money to SNA. Okay, I'll show you the message in a little bit, so you will be on board with me.
I really hope that she wasn't
And she's like, we need to talk to Abby. And I'm like, if
like,
Abby wanted something, I know she would talk to me easily. So I was like, I think maybe Bree talked to her and just threw you into it.
we
but
just talked about it
that's
in
okay.
clinical,
Okay,
just
yeah,
in
but
general,
that's
like a
okay.
group thing, but she's like trying to get us to join, and I was like, rather than spending the $40 to join, I'm just gonna donate my time and efforts for making like 50 headbands, you know, and then if you guys have a booth or something, we can, like, I'll be there, I'll be selling them, you know, like, that would be my contribution. I was about to say you're going to charge. No, I don't intend on like selling $700 worth of headbands
Yeah.
for you guys and then donating money.
Okay. Gotcha. Because I was like, okay, I'll talk to Abby about it, but like, whatever. But okay, that's fine. Okay, so Mandy messaged me and said that I need to bring up things at the meeting. And I said, okay, that's fine. Like, but I think I'm just gonna be like, well, I mean, whoever wants to talk, are you gonna go to the meeting? She said that it would. She hasn't posted it yet. But it'll be after spring break. It'll be like the Monday after spring break.
If you can
She
remind
was
me.
talking about it.
Because,
But
I
she
mean,
said she'll send out an email. If
Okay.
you're a part of the SNA, then you'll get an email
Yeah, I
stating.
joined.
Okay.
I don't do anything, but I joined.
Yeah, well, you don't have to. I don't do anything. I mean, I'm the president of it, but I haven't done anything yet because Mandy has had, the assessment class. She wants to get it done and over with, get all them tested out because it's too much on Friday. You know.
Because I still haven't gotten
That's why that was fine. It didn't matter. Like, we have until the end of next semester to make sure that we have the money to graduate with.
I got my state taxes back.
Did you get one?
$100 and some dollars, so I haven't got my federal
On
taxes
Saturday,
yet.
I'm getting it.
But usually
I
I
love
do
it
get my
here.
state taxes
It's a Maine Coon, so it's gonna. Oh my god, it's gonna be giant.
first.
A boy or girl?
Oh,
Yeah, definitely a girl. I wouldn't want a boy.
It's beautiful though.
I
It
know
has
how
beautiful
much
hair.
What if I don't get them?
You're gonna have a cat bigger than my like small dog.
Right.
This nurse I work with, she just sent me the screenshot from the group, and she's like,
ears. Those are amazing.
yeah.
Yeah. I literally look every single day and it says still processing. And I'm like,
To enthusiastic about it.
but then I listened to my friend the other day saying something about the
Yeah.
stimulus
So
check.
here's a very like dog-sized cat.
Yeah, dog-sized cat.
Silas is like a little dog.
I thought Alyssa got it, but if she's
That
saying
cat
she
is so
didn't.
gonna beat up on that dog.
She has like to do something.
Yeah.
She's gonna go to get
I
it.
love it.
But we haven't done that yet. But I should have talked about it the other day.
I like to bring one of those cats into my house with my mean, because I have a mean ass cat.
For her refund.
She don't like no other animals. She don't like you go to pet her and she like, and I'm like, why? You want
Okay, I
to be
think
petted?
everybody's about back. Let's go ahead
She's
and start
PMS.
back and see if we can finish the business after today. So we were talking